Hello friends, I am Dr. Nitin Nema, Assistant Professor at Department of Pharmacology, Sagar Institute of Pharmaceutical Sciences. Today we are going to learn about appetite suppressant. So let's have a general introduction and background information about appetite suppressant. And what we are going to learn in this informative episode, we will start this lecture with a background information followed by health consequences of obesity, then factors influencing body weight and benefits associated with weight loss. After that, we will try to understand pharmacological treatments for obesity and interventions, and at last, before ending the lecture, I will discuss with you about future therapies. Let's start today's lecture with some background information. Obesity is a chronic relapsing disease in which there is an abnormal accumulation of body fat. Definitions and measurement of obesity vary, but most researchers currently use BMI, body mass index, to classify individuals in terms of weight. Individuals with a BMI of 30 kg per meter square are generally considered to be obese. Table 1, classification of body weight: normal 0% and BMI 18.5 to 22.9 kg per meter square. Overweight 20%, for 10% above ideal weight, it is 23 to 24.9 kg per meter square. For obese, class 1 20 to 40% above ideal weight and BMI is 25 to 29.9. Class 2 range 40 to 100%, that is less than 30% BMI. Class 3 more than 100%. Figures taken from WHO, the Asia Pacific perspective redefining obesity. Generally, BMI correlates well with body fat. However, BMI is not a foolproof guide to morbid fat accumulation, as it does not take into account body frame size, proportion of lean mass, age, gender or ethnic differences. Other useful but less commonly used obesity indices include waist to hip ratio and waist circumference. These measures may provide additional useful information regarding risk factors associated with weight gain. Hope you have got a clear idea about BMI and obesity. Now let's proceed to the health consequences of obesity. It was estimated that the health risks associated with obesity were equivalent to a number of high risk chronic diseases including type 2 diabetes, heart disease, hypertension, stroke, gallstone and some cancers. Increased health risk for condition associated with obesity vary from substantial to moderately raised risk for diabetes, heart disease, hypertension and a number of other metabolic disturbances to a slightly raised risk for some cancers and lower back pain. Table 2, obesity related comorbidities and risk. Substantial risk increase where relative risk is more than 3 for type 2 diabetes, gallbladder, dyslipidemia, metabolic syndrome, sleep apnea and breathlessness. Moderate risk increase in terms of relative risk equals to 2 or 3 for coronary heart disease, hypertension, osteoarthritis of knee and hips, hyperuricemia and gout. Slight risk increase for relative risk ranging from 1 to 2 for breast, endometrial and colon cancer, reproductive hormone abnormalities, polycystic ovary syndrome, impaired fertility, low back pain, increased anesthetic risk, fetal defects, maternal obesity. Relative risk is the probability of an event in the treatment group divided by the probability of the event in the control group. After learning about BMI and health consequences of obesity, it is important to know about the factors influencing the body weight. In this module, we are going to learn about the same. A number of factors influence body weight and fat levels, make some individuals more susceptible to obesity. Known contributions are ethnicity, gender, age, hormone state, genetic makeup. People from Southern Asia are at a greater risk of developing central obesity, and their cardiovascular risk increases rapidly at a lower levels of obesity relative to Western standards. For this ethnic group, increased cardiovascular risk starts at a BMI of 21 to 23 kg per meter square. The WHO has proposed new obesity guidelines for Asian populations with an obesity threshold defined as a MI 25 kg per meter square. Individuals with a certain learning disabilities such as Down's syndrome are also higher risk of obesity. NHS Center for Reviews and Dissemination 1997. Hope this lecture is quite informative and explanatory to you. Now let us move to our next module, that is about benefits associated with weight loss and pharmacological treatments for obesity. Even a modest weight loss of 5 to 10% has been associated with significant health benefits in the obese patient. These benefits arise from improvements in obesity related to comorbidities including blood pressure, blood glucose and cholesterol levels. It has been estimated that for every 1 kg reduction in body weight, there is a 0.05 millimole per liter decrease in total cholesterol, 0.02 millimolar per liter decrease in low density lipoprotein cholesterol, LDL cholesterol 0.015 millimole per liter decrease in triglycerides, 0.007 millimole per liter increase in HDL high density lipoprotein cholesterol. Weight loss and dietary fat modification appear to have an independent and additive effects on the reduction in serum lipids. The net favorable effect of weight loss seems to be greater than that of dietary fat modification, as a weight loss per se is only responsible for about 60% of the fall in LDL cholesterol and 70% of the fall in triglycerides. Every 1% reduction in glycated hemoglobin decrease cardiac complications from 9 to 40% depending upon the population and diabetes type. Higher weight losses have greater benefits. A 10 kg weight loss may be expected to incur 10 mmHg decrease in systolic blood pressure, 20 mmHg decrease in diastolic blood pressure, 91% reduction in angina symptoms, 33% raise in exercise tolerance, 10% fall in total cholesterol, 15% fall in LDL cholesterol, 30% fall in triglycerides, 8% increase in HDL cholesterol, more than 50% reduction in the risk of developing diabetes, 30 to 50% fall in fasting blood glucose, 15% fall in HbA1c. Pharmacological treatments for obesity are limited. Most have the potential to produce undesirable side effects. Additionally, amphetamines administered for the purpose of weight loss and may have euphoric action and carry the potential for abuse. Some previously available products have recently been withdrawn from market in a number of countries. For example, phenyl propenelamine, an appetite suppressant, has been associated with increased hemorrhagic stroke in women and withdrawn in few countries. Fenfluramine and dexfenfluramine, two centrally acting appetite suppressants, are predominantly by releasing serotonin, were also withdrawn from the market recently because of an association with pulmonary hypertension and coronary valve damage. Now, here we come to our module pharmacological intervention, in which we will try to understand about drugs and interventions prescribed in the treatment of obesity. There are currently 4 generic drugs prescribed for the treatment of obesity: phentermine, diethylpropion, orlistat, sibutramine. Other non-pharmacological interventions include meal replacement products and plants and surgery. Phentermine. Phentermine has been available since 1960s with a reported worldwide exposure of more than 50 million prescriptions. It is available in 15 or 30 milligram doses or in a sustained release hydrochloride form. Phentermine is an appetite suppressant chemically related to amphetamine. It has its main effect on the dopaminergic and noradrenergic nervous systems, and the action include central nervous system stimulation and blood pressure elevation. The resin complex is insoluble until it reacts with GI fluids. Phentermine is then released from the resin throughout GI tract over a period of 10 to 14 hours. Phentermine hydrochloride sustained release capsule has peak concentration at 2.4 hours after ingestion. There is almost complete absorption of the drug, but eventually 70 to 80% of the oral dose is excreted unchanged in the urine, with a remainder metabolized by the liver. The half-life of phentermine is about 25 hours. Phentermine use in children under 12 years, elderly patients and pregnant or breastfeeding women is not advised, as safety and efficacy in these populations has not been established. Doses and administration. The starting dose is usually 30 milligram per day. However, in light framed patient or those who have suffered side effects from a dose of 15 milligram per day may be prescribed. Failure to achieve a weight reduction of 5% within 12 weeks of starting phentermine therapy, there is an indication for discontinuation of treatment. In order to reduce the risk dependence, the maximum continuous period of treatment should not exceed 4 to 8 weeks. Use. Phentermine may be used as a short term adjunct in a medically monitored comprehensive regimen of weight reduction based on exercise, calorie control diet and behavior modification in patients with a BMI equal to 30 kg per meter square, who have not had an appropriate clinical response to an appropriate weight reduction program alone. Patient with a obesity related comorbidities such as sleep apnea, insulin resistant diabetes mellitus, pre-diabetes mellitus or impaired glucose tolerance, or high cardiovascular risk status, and have a BMI of less than 30 kg per meter square may also be considered for treatment with phentermine. Mode of action. Phentermine is an amphetamine which operates by stimulating the release of noradrenaline and dopamine. It also inhibits monoamino oxidase. Its central catecholamines mechanism cause appetite suppressant for 12 to 14 hours. Indications. Phentermine 15 milligram and 13 milligram are indicated as a short term adjunct in a medically monitored regimen of weight reduction in obese patient that include a calorie control diet, exercise and behavior modification. It may also be appropriate to use phentermine in overweight patient with an increased risk of morbidity from other medical conditions including sleep apnea, insulin resistant diabetes and cardiovascular disease. Contraindications: patients with pulmonary artery hypertension, heart valve abnormalities or heart murmur, moderates to severe hypertension, cerebrovascular or cardiac disease, hypersensitivity to sympathomimetic drugs, hyperthyroidism, agitated states or eating disorder, glaucoma and patients with a history of substance abuse or dependence. Warning and precautions: serious cardiac valvular disease and primary pulmonary hypertension has been reported in patients who have taken phentermine and fenfluramine or dexfenfluramine combinations for weight loss. There have been no reported cases of valvular disease and only very rare cases of PPH in patients taking phentermine alone. There is also a theoretical risk of cardiac valvular diseases if phentermine is combined with selective serotonin reuptake inhibitors such as fluoxetine and paroxetine, ergot derived drugs and clomipramine. Phentermine should not be administered with monoamine oxidase inhibitors and should be used with caution in patients with mild hypertension and patients under treatment with hypertensive agent, as it may cause some loss of blood pressure control. The ability to perform activities requiring mental alertness such as driving and operating machinery may be impaired while taking phentermine. Diethyl propion hydrochloride is an appetite suppressant or anorexiant. It is rapidly absorbed after oral administration with 75 to 100% of the dose excreted in the urine as diethyl propion hydrochloride or its metabolite. The half-life of diethyl propion in the plasma is about 2 hours and excreted half-life of the drug and its metabolite is approximately 10 hours. The use of diethyl propion in children younger than 18 years and pregnant or breastfeeding women is not advised, as safety and efficacy in these population has not been established. Secondary organic causes of obesity should be included by diagnosis. Dosage and administration: the recommended dose of sustained release diethyl propion is 75 milligram once daily, 1 hour before meals. It is intended for short term intermittent use only. Courses may be given over a period of up to 12 weeks with intervening period of at least 1 month without treatment. To limit unwanted exposure, treatment should be continued only if there is satisfactory weight loss within the first 4 weeks of treatment. Insulin requirements may be need to be altered. Use: diethyl propion may be used as a short term adjunct in a medically monitored comprehensive regimen of weight reduction based on exercise, calorie restriction and behavior modification in obese patient with a BMI 30 kg per meter square who have not an adequate response to an appropriate weight loss program of diet and or exercise alone. Patients with a BMI of less than 30 kg per meter square with a comorbidities including sleep apnea, insulin resistant diabetes mellitus, pre-diabetes mellitus or IGT or high cardiovascular risk status may require medical assistance with weight loss. Such patient may also be considered for treatment with diethyl propion. Mode of action: Dilethylpropion is a sympathomimetic amine. It acts as a CNS stimulant, increasing the heart rate, raising the blood pressure and decreasing the appetite. Indications: diethylpropion is indicated as a short term adjunct in a medically monitored comprehensive weight loss program based on calorie restricted diet, exercise and behavior modification in obese patients who have not achieved an adequate weight reduction using diet and exercise alone. Overweight patients with sleep apnea, insulin resistance diabetes or with a high risk of cardiovascular disease may also be considered for treatment. Contraindications: severe hypertension or pulmonary artery hypertension, advanced arteriosclerosis, hypersensitivity to sympathomimetic amines, glaucoma, agitated states and patient with a history of drug abuse, failure to achieve a weight reduction of 5% in a period of 12 weeks is an indication for discontinuation of treatment. Use in conjunction with other anorectic agent is contraindicated. Warning and precautions: dilethylpropion should not be given during or within 14 days of monoamino oxidase inhibitors. It is not recommended for patients who have taken any anorectic agents within the prior year and for patients with a heart murmur or valvular heart disease. The use of anorexiants has been associated with PPH and an increased risk of PPH with repeated courses of therapy cannot be included. Epileptic patients should be carefully monitored. Dilethylpropion should be used with caution in patients undergoing general anesthesia. Sibutramine hydrochloride. Sibutramine is an orally administered drug that promotes satiety after eating and stimulates energy expenditure. It is the first product of its type to be used for the management of obesity. The drug is rapidly absorbed following ingestion with maximal plasma concentrations at 1 hour and an elimination half life about 1 hour. Most 77% of the drug is absorbed from GI tract and up to 85% of the oral dose is excreted in the urine and feces. Sibutramine and its metabolites do not enhance dopamine release and have not been shown to have a potential for abuse. The long term effects of sibutramine on the mortality and morbidity associated with obesity have not been established. Its use in the obese children under 18 years, patient over 65 years and pregnant or breastfeeding women is not advised as safety and efficacy in these population has not been established. Doses and administration. The recommended starting dose is 10 mg once daily with or without food. In clinical trials, sibutramine was given in the morning. If there is less than 2 kg weight loss after 4 weeks and 10 mg dose is well tolerated, the daily dose may be increased to 15 mg. Patients usually achieve a maximum weight loss that is 5 to 10% of initially body weight after 6 months of treatment. The European Union label states that patient responding well may be treated for up to a year. In the USA, treatment may be maintained for up to 2 years. The frequency of adverse events may be reduced if sibutramine is administered intermittently, that is alternating with a placebo or drug free periods. Use: sibutramine may be used for the management of obesity including weight loss and weight maintenance in patients with a BMI 30 kg per meter square or a BMI of 27 kg per meter square in patients who have diabetes, dyslipidemia or hypertension. It is intended for use when patients have not adequately responded to appropriate weight reducing therapy such as hypocaloric diet and or exercise alone. Example: patients having difficulty in achieving or maintaining a 5% weight loss within 3 months. Mode of action: sibutramine is a centrally acting monoamine reuptake inhibitor which blocks the presynaptic reuptake of serotonin and noradrenaline, thereby potentiating the anorexic effect of these two neurotransmitters in the CNS. Indications: sibutramine 10 mg and 15 mg is indicated as adjunctive treatment within a weight management program for patients between 18 to 65 years with a BMI of 30 kg per meter square, that is obese, or patient with a BMI 27 kg per meter square, that is overweight, who also have type 2 diabetes or dyslipidemia. Patients must have failed to lose weight on diet and exercise in the past. Contraindications: patients with severe hepatic or renal dysfunction, hypersensitivity to sibutramine, organic obesity or history of major eating disorders, patient with psychiatric illness, drug or alcoholic abuse, inadequately control hypertension or history of cardiovascular disease, narrow angle glaucoma, hyperthyroidism, benign prostatic hyperplasia with urinary retention and pheochromocytoma. Warning and precautions: blood pressure and a pulse rate should be monitored while patients are taking sibutramine. The ability to drive a vehicle or operate hazardous machinery may be impaired when taking sibutramine. Orlistat. Orlistat is a novel anti-obesity agent that inhibits the digestion of fat. Undigested triglycerides are excreted in the feces 24 to 48 hours after administration, resulting in a caloric deficit that has a positive effect on weight control. Orlistat is a minimally absorbed into the systemic circulation with approximately 97% of the administered dose excreted in the feces. 83% is unchanged orlistat. The time to complete excretion is 3 to 5 days. The long term effects of orlistat on the mortality and morbidity associated with obesity have not been established. Its use in children, adolescents below the age of 18 years, patient over 65 years and pregnant or breastfeeding women is not advised, as safety and efficacy of this population has not been established. Dosage administration: the recommended dose of orlistat is 120 mg 3 times a day with each main meal. Higher doses have not been shown to provide additional benefit. The greatest weight loss occurs within the first 6 months of treatment. In the USA, the treatment may be maintained for up to 2 years. Use: orlistat may be used for weight loss, weight maintenance and prevention of weight regain in adults with a BMI greater or equal to 30 kg per meter square. It should be used in conjunction with a low fat calorie controlled diet that is nutritionally balanced, rich in fruit and vegetables and contains approximately 30% of calories from fat distributed over 3 meals. Mode of action: orlistat is a synthetic derivative of lipastatin, a naturally occurring lipase inhibitor produced by Streptomyces toxidricin. It is a potent and specific irreversible inhibitor of pancreatic and gastric lipases that acts by bonding at the active site of lipases in the lumen of GIT. The inactivated enzyme is unable to hydrolyze ingested triglycerides into free fatty acids and monoglycerides for absorption. At the recommended dose and when diet contains approximately 30% of calorific intake from lipids, about 20 gram of fat is excreted in the daily stool. Orlistat may also influence dietary choices, as high fat meals can lead to be more severe GI adverse events. Indications: early state is indicated as a adjuvantive treatment within a low fat calorie controlled program for obese patients between 18 to 65 years with a BMI of 30 kg per meter square. Patient must have demonstrated weight loss of 2.5 kg 1 month before its use. Contraindications: patients with a chronic malabsorption syndrome, cholestasis, known hypersensitivity to early state or any of its components. Warning and precautions: because of a possibility of a decreased absorption of fat soluble vitamins A, D, E, K and beta carotene, the use of multivitamin supplements may be considered while patients are taking early state. High fat meals are likely to increase the possibility of GI event, and patients should adhere to dietary fat intake guidelines. A reduction of plasma levels of cyclosporins 5 is possibly after early state administration. The effect of amiodarone may also be reduced. Coagulation parameters of patients on concomitant oral anticoagulant should be monitored. Future therapies is our last module of today's lecture. Though research in this field is a continuous process, but some of few potential therapies of future to cure obesity we are about to discuss in this module. There are number of potential future therapies for obesity. Leptin is a hormone released from adipocyte which signals energy availability to the brain. Its deficiency leads to severe obesity, and most obese individuals have been found to have elevated leptin levels. However, like most diabetics, most obese people are leptin resistant. There have been a number of phase 2 trials of this agent with disappointing results to date. Exocrine is recombinant human ciliary neurotrophic factor which has been observed to cause weight loss, and in rodents does not lead to rebound weight gain upon cessation. Early phase trials have indicated that weight loss in excess of placebo is obtained and that weight loss is maintained after treatment has ceased. Topiramate is an anti-epilepsy drug that has been evaluated for weight loss. A recent dose ranging study has suggested that a clinically significant weight loss and improvement in obesity associated risk factors may be obtained with the therapy, but longer and larger studies are required to fully assess its efficacy and safety. Bupropion is a peptide analog of the fragment of human growth hormone that causes lipolysis. Now, here we comes at the end of today's topic, that is appetite suppressant. Before I said you goodbye for next session, here we may recap what we have learned today. In today's lecture, we have got a brief idea about general introduction and background information about appetite suppressant, and followed by health consequences of obesity, then factors influencing body weight and benefits associated with weight loss. After that, we try to understand pharmacological treatments for obesity and interventions, and at last discussed with you about future therapies. Hope it was quite interesting learning session. I will meet you again with other interesting episodes in coming days, but if you want to know more and learn, you may visit to our website https://cec.nic.in/ for more interesting facts, lectures, quizzes, frequently asked questions and many more. Till then, goodbye and keep learning.